Good evening. Thanks so much for joining us tonight. We're very fortunate to have a fantastic group of faculty members to share with us their tips and tricks on maximizing volume and minimizing complications. I'd also like to thank my co-host, Dr. Hafiz Kassam, who helped organize this lecture series with us. I'd also like to thank Smith & Nephew, who's been the sponsor of these webinar series.
Good evening, everyone, and welcome to the ASCS Foundation webinar series. I'm Scott Gunn, Vice President of Shoulder Marketing and Sales at Smith & Nephew. As the sole sponsors of this series, we're thrilled to have the opportunity to introduce you to Smith & Nephew and our innovative product portfolio. For over 100 years, Smith & Nephew has been at the forefront of medical technology, committed to improving lives through our pioneering solutions. We're excited to share our latest advancements in shoulder arthroplasty and sports medicine. Our team of experts have been focused on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the elegant ATOS shoulder system, which embodies stability, simplicity, and flexibility. ATOS is a streamlined system for both anatomic and reverse procedures, allowing for an elevated operating room experience. Throughout this webinar series, you'll hear from leading experts in the field who will discuss the latest research, clinical evidence, and best practices in shoulder and elbow medicine. Thank you for joining today, and we look forward to sharing our passion for innovation and helping you provide the best possible care for your patients.
Perfect. Thanks, Steve, for playing that. And I think with that, we're going to go ahead and get started this evening. We're also going to be recording this. This will be available for future listening as well. We're going to start out tonight with Dr. Jalwa, who's going to share with us about organizing his team to maximize efficiency and patient satisfaction. Andy, thank you so much for being here with us this evening.
Great. Thank you to John and Hafiz for having me here. I'm going to be talking about how I organize my team to maximize efficiency and patient satisfaction coming here from Boston. These are my conflicts. The major conflict here is I'm an owner of an outpatient ASC. So take everything I say with a huge pile of salt. And the reason is everybody's situation is totally different. My situation in an academic practice is totally different than my private practice now. Everybody has different goals and values. Some people value free time more than money. Some people value their kids. Some people don't value their kids. So it's going to be different for everybody. And then, I am not a super high volume surgeon. I do more than 400 arthroplasties a year, but there are people like Derek Cuff, Ryan Krupp, who do that plus 200, 300 more arthroplasties. But I am efficient. I do education. I do a lot of research. I run our private practice. So I'm able to do a lot of things, but I'll give you some of the tips that apply for me. My basic principle, the foundation to everything, is patient satisfaction. If your patients are happy, I'm happy, the staff is happy, and it is the best marketing. There's great marketing you could do on social media, but the best marketing is when you have happy patients. You do their other side, et cetera. I follow my patients very closely. This is for research, but it also helps me understand who's satisfied, what my complications are, and I can track them. Slow is smooth and smooth is fast. Anand calls me slow all the time, both mentally and physically, and I play towards my strengths. And so I really believe I'm not one of these guys who goes frenetically from room to room. I go slowly, but I do it with efficiency, and that works very well for me. I'm not late to my patients. I'm always on time, and that works well. And we're constantly reevaluating what works and what doesn't work. I am a better surgeon and a faster surgeon than I was 10 years ago, and that changes how I practice, and that constantly is changing what we do every day. Really, this starts with a great team, and my administrative assistant made this for me, and she is really the key. This is Marie. She is the best administrative assistant I've ever had. She's great with patients. She's organized. She helps run my practice life, my family life, and my schedule. And once you find somebody that's great, stick with them, pay them extra. They're really the key. My PA, and I'm probably understaffed in PAs. We're looking for a second PA, so over-resourced, but spends all the OR time with me and does his own clinics. And we'll talk about that. He's better than most fellows, and having somebody who's great at what they do is very helpful in managing patients. I do a lot of research. This is Originally, I paid for them. Now they're paid for by our foundation, which we've created. They interact with me. It's a little bit of a social contract. We try and get them into medical school or PA school, and they publish a lot of papers, and it works really well. My MA, we work with 1 or 2 MAs in our practice who know our practice extremely well. And that's really key. They help me with notes, et cetera, and putting patients in room and what we need. And we'll get into that in a moment. Once you get enough volume, you have excess. That's when you get a partner. That's when they get an AA. That's when they get a PA. And we're just a small microcosm within a large group of about 25 surgeons, which is a subset of even a larger multi-specialty group in New England. Where's the fellow in all this? Fellows to me are learners. They're not part of my workflow. I want them to learn and not have to be doing all the work, which is very different than how I train, but that's really critical. We can have a discussion about if people agree with that. So the clinic, how do I organize my clinic? I believe in overeducating patients. So we have a 15-minute video that we produce on our own with our own money. It's in 8th grade language. Everybody watches it when they see my PA and sometimes when they see me. We have a book that's 60 pages, soup to nuts on shoulder arthroplasty, has all my complications, patient satisfaction, how everything works. We edit it every year. On the 3rd page has Marie's phone number, direct line to her, which is really critical. Clinic. So I only do clinic twice a week. I have a 7 a.m. start. My PA sees all my new patients. If you asked me 10 years ago if this is good care, I would say absolutely not. They want to see you. We are so busy now that he sees all my new patients in a parallel clinic, which he makes money doing. We have a common admin, which is Marie. If there's an issue, I see them. We see them pre-op, 2 weeks, 6 weeks, 3 months, 6 months if there's an issue, 1 year, 2 years, 5 years. And I do pretty much all arthroplasty. They see Kiet or me in alternate cycles. So Kiet is me. They view us as a team, and it works very well. And this works very well for our research. I do not see a lot of patients because spending a lot of time is really critical, but I have a pretty high hit rate. So I only see 25 to 30 patients. We used to see a lot more. I see 8 to 10 patients a day, of which I book about 8 for surgery. I actually spend most of my time trying to convince patients not to have surgery. So I really try to under-indicate. I used to have a scribe. Now I have an AI scribe. I know Quinn has talked about how it didn't work for them. Mine works for me, the one we use. My MA also puts in sort of pre-made notes in certain things because I talk about the same ways that the complications and the risks, et cetera. So he can do that. I read them and they're done by the end of the visit. I do a lot of research, assistant interaction in between cases. That's how we get a lot of research done. They're very resourceful. I'm always on time. I never try and overbook, and that works very well with patient satisfaction. This is sort of an example. This face sheet comes from every new patient. So this is, a patient that saw Kiet originally. I saw this patient on January. In January, they saw 4 days after Kiet saw them. Usually it's about a 4-week lag time when they see my PA and they see me. This was just an unusual one. This patient's already booked for surgery at our outpatient surgical center. We have this face sheet a lot from Quinn's work. Do they have home help? Do they have cardiac issues, breathing issues? What's their BMI at our ASC? It has to be less than 35. Do they take testosterone? And when was their last injection? So we already sort of pre-screened this patient for an outpatient surgery. And Quinn did all this work with Tyler in the Campbell Clinic, and we use this. Age less than 75, BMI for us 35, appropriate social support, no assistive devices, and then they get a pre-screen. And our workhorse is our ASC for efficiency. In terms of the OR, this has evolved over time. I do it 3 times a week. I am limited at the hospital. I don't get 2 rooms all the time. And so that's been changing over time. The ASC is the workhorse, especially because we can do Medicare patients at an ASC. Staggered rooms, we can do 5 to 6 in a day. Revisions are at the hospital. I always do my most complex cases last, so I pre-screen them ahead of time, look at their CTs and the planning. The PA sends scripts ahead of time to all my patients, so they have them before they come to the OR. He uploads all the CT scans for planning 2 weeks ahead of time, and I call all my patients the night before. They love that touch point. I confirm that they have their all their medications, and they really like them. They talk about that many years later that I call them the night before. It works really well. Things that I think are unsuccessful that I've seen, trying to do it all yourself. I try to over-resource. I pay for that, but it really pays in spades in the end. Seeing too many patients, I did that before. I think seeing fewer patients, spending more time with them is really the underpinning of patient satisfaction. Making a fellow critical to the workflow. I really think they're learners and they shouldn't be in the workflow. They should be there to learn and you teach them. I have become very narrow in scope. I used to do fingertip to shoulders. By being much more specialized, I've been able to standardize and become extremely efficient. Unfriendliness. I see this in some surgeons. It's so important to be friendly to everybody, your staff, the people at the cafeteria. I get more patients sent to me from the hospital staff than referrals. And so it's really key to be friendly and be professional. Don't over-indicate surgeries. It's better to under-indicate, and your patients will be happier. Last thing is I'm constantly reevaluating, how to make our practice more efficient and better. And we do that, every month, every day in the OR. I talk with Kiet. How do we do this better? Takeaway points. Patient satisfaction is key. Over-resource, team mentality, professionalism, friendliness. Constantly reevaluate. And there's some serendipity here. People on this call, Anand Murthy, meeting him has helped my career more than anything, frankly. And so, don't think you hit a home run when you were put on third base, as my wife always reminds me. So always think about that and be humble. Thank you.
Andy, what a great talk. Really appreciate that. Really well done. I think for the folks attending, please feel free to put any of your questions in on the chat. It's interesting, Andy, and every time we do these, you learn some tips and tricks. I love that that touch point where you call patients the night before surgery. What a great thing to do, and what a nice personalized touch in your practice. How long have you been doing that for, Andy?
So there's a surgeon you may or may not have heard of named Dick Scott, a very well-known knee surgeon. And in residency, he told me he did this. And so I've been doing it ever since practice started. And it has been amazing. People still remember that years later. And when you don't see a patient for 6 weeks or 3 months prior to surgery, and you call them the night before, and they know you're thinking about them, they feel at ease. It really helps.
Yeah, what a great idea to be able to do.
Andy, quick question. You talked about your efficiency in the OR and planning complex cases at the end. So, I do a similar thing. So, and I've heard questions back and forth. So can you explain a little bit more on your thoughts of why you put complicated things at the end, not the front, when maybe you're more tired or maybe you can get through it quicker? What's your rationale for that?
Yeah, I think it's a couple things. I think it's hard to think in the heat of battle, and in revisions, you need to be not worried about your next case. I don't want to be like, oh man, I'm 3 hours late. I just fractured the humerus. I want to be fully focused. And, if I have to go a couple hours later, that's what I want to do. I don't want to feel rushed. That's why I do it. There is the downside that you feel a little bit more tired. I do book less cases when I have a revision at the end, and I will sort of categorize them as revision light. Ones that I have to remove the humerus, have bone loss and the glenoid. I will book fewer cases that day than something that's, a hemi to a reverse.
I agree with Andy. They're just sometimes unpredictable, the reverse. And you don't want, patient, along with the patient satisfaction, you don't want primaries kind of sitting around waiting too far past their booked time. So I did the same thing. And I took a note from Andy a year ago where he's kind of, right, Andy, you rank each case by number and they have to add up to a certain amount per day. So I gave my admin that. It makes it easier for administrator. Primary simple's a 1, revision light's a 2, massive revision's a 3, and they have to add up to 12 or something, And so that's a good way when you get to be kind of higher volume, have some revisions.
Yeah, my fellows ask me about that all the time, and my only answer is I've learned to be efficient because I think of myself as the least important person in the workflow. Because I think if you're tired, you get that, but if you kind of prioritize the people around you and prioritize your team, and things just kind of move on a little bit quicker. So maybe I can take advantage of that. But appreciate it.
Andy, superb. Thank you so much. And next, Quinn's going to help share with us a little bit some of the lessons they've learned at their institution. As you just heard from Andy, they really were the pioneers on outpatient shoulder arthroplasty, and look forward to hearing from Quinn tonight on more of the lessons he's learned in this way. Quinn?
Well, thanks, John, and thanks, Andy. You really set the table nicely there. And we're I think tonight we're gonna have a lot of overlap in some of these presentations. Like Andy, my main conflict is ownership of two surgery centers that are directly owned by the Campbell Clinic. So we talk about value-based care. I continue to do this. I just got back from the Ortho Forum about an hour ago, and the only thing that was talked about in terms of driving revenue is patient volume. So that is still the case in 2025. We work in a volume-based business. Maybe we'll get to value-based care someday, but
Hey,
we're
Quinn,
not.
Andy just said to see fewer patients.
That I did not hear that once the entire last week.
So I will add one thing is that it's a wave, right? So right now, when it's still a fee-for-service model, right? You don't want to be too far ahead of the wave or too far behind the wave to go to the value-based healthcare. And so all of us live in that fragmented market space. Where I am right now, it's less than 5% of the revenue stream for the entire multi-billion-dollar organization is value-based healthcare.
Yeah, amazing.
Yeah, and these are articulated goals by CMS, but they're certainly not fully fleshed out and fully functional at this point. But there's been a lot of emphasis on cost containment, and really, when you think about this, these strategies do not charge the hospital, nor the insurance company, nor the rehab facility, nor the patient, and darn sure going to be the government that's going to take responsibility for this. So this falls on the surgeon, which is fine. Actually, the better that we are having a seat at the table, the more influence we have in terms of directing change. It's better for our patients and better for ourselves. So we've talked about outpatient shoulder replacements. Andy mentioned some of our work on that, but really what it is an opportunity to transition care to a place where you have more control, i.e. the surgery center. We all know that we don't have much control in the hospital unless we own it. When you're even if you're an investor and not necessarily a full owner of a surgery center, you definitely have more control over the service line and a better opportunity, therefore, to cut costs and control quality. Of course, we're sort of in an era where outpatient joint replacement is standard at this point. So my assignment is to talk about service line control, or at least cooperation, and to go through some of the financial aspects. And honestly, this really depends on situation, like Andy mentioned, because the level of control that you have really varies by practice type. And so not everything that I'm going to say here is going to apply, but the things to pay attention to are OR services, meaning who assigns the rooms. Andy can't get 2 rooms if he doesn't have made an argument to the people that make that decision. Getting good techs and circulators. We talked about team already. Well, my OR team is very, very important to me. I incentivize them and bonus the crap out of them at the end of every year. SPD is a big deal in the outpatient surgery center. Not everybody has the infrastructure to deal with the multiple PANs that come with doing high volume joint replacement, not just shoulder, but hip or knee. And then pre-op and PACU personnel, unless they're properly trained, can be a problem. If you're in a surgery center where they're used to punting somebody out the door 3 minutes after a carpal tunnel, that's different than a joint replacement. Anesthesia, the surgeon's bane for as long as we've ever been in practice. But the key variable here is, to whom are these folks responsible? And ideally, they're responsible to you as the owner of a surgery center, or at least have some sort of a service line management agreement if you're in a hospital. But that's not always the case. And so in employed or academic practice, you often have minimal control over these things. And it doesn't mean you can't do it. It just takes longer. It really requires a lot of meetings with suits, basically, to carve out a program. In a private or private-demic environment, like, we have full control over the OR services. We have fairly substantial control over anesthesia, and I'll talk about that a little bit, but it really depends on the services agreement. Who are they contracting with? And so in the private environment, you do have more freedom, but you still have to get buy-in. You still have to go to some meetings in order to get everybody on board. So talking a little bit more about service line management, we talked about OR services and the things that go into that. But the key thing is that to try to set things up so that the employees are responsible to the surgeon as much as possible, and ideally have physician oversight. For instance, our surgery center board is run by physicians. We have a surgery center manager, but every voting member of that board is a Campbell Clinic physician. So that therefore we have lots of control over block time and room utilization, as well as OR team assignments. We have a say in training the pre-op and the PACU. And as I said, this is best done with a surgeon-led committee. If you ever want to solve a mystery, you get a medical doctor. If you ever want to solve a problem, you get a surgeon. And so everything that we know is that when you put a surgeon in charge of a problem, the problem gets solved. But that takes us to anesthesia, and my intent here isn't just to bag on our brethren, but they have been a force for good and evil throughout our journey in outpatient shoulders. But again, it goes back to the services agreement. And so if you are at a surgery center, even if you're an investor, but the managing entity is either the hospital or the ASC or some other LLC, you're going to have minimal control because those folks aren't responsible to the surgeon. Again, in a surgeon-controlled entity, we were fortunate to set things up where we have more control. Never, ever let anesthesia control the OR board if you can help it. I realize that's easier said than done. And then negotiating for adequate OR coverage with your anesthesia provider. So we contract with a number of anesthesia groups actually over the years, and we have staffing requirements written into the contract so that we can run 2 rooms when we need to. And there are penalties for not meeting those requirements. And there's also metrics for pre-op evaluations and same-day cancellations so that they're held accountable for providing good care. Cost control, again, less relevant if you're a hospital employee, but yeah, we're going to talk a little bit about implant costs and disposables and bundle negotiation. The bottom line here is that implant costs are the #1 driver of the financial considerations of outpatient joint replacement. So I'll take you through our journey, as it were, at our place. Our first total joint replacement was actually a shoulder. It was done in 2012, and we were just sort of going ad hoc with our private insurers at that point. And doing grouper fees basically, but we sort of realized that this was something we really wanted to expand on, and now we're up over 5,000 outpatient joint replacements, with about a tenth of them being shoulders. But 95% of our commercial business is under bundles at this point, and I'll talk about what that means in a little bit. We talk about it as a bundle; it's really called a carve out. But first, you need to understand your market dynamics and really your role within the market. Because if you don't have a big enough book of business within the market and with the insurer that you're approaching, then you are not important to them. And of course, what's important to them is to have the lowest possible reimbursement and the least possible cost. But you need to also have a big enough book of business where it's worth it to them to pursue this. Same thing with hospital systems. Again, in ASCs, sometimes they're powerful enough to influence your penetration or your transfer of cases to the surgery center, although I think that ship has sailed for the most part. I really, for the last several years, have not heard of any hospitals that have obstructed an initiative. Maybe there's some stories out there. I just haven't heard it much because I think the hospitals have figured out, hey, we drive folks to our HOPD surgery center, and we're going to do pretty well on this. Again, you need enough cases, like I said, and I think what this practically means is you have to have a hip and knee component to really get insurance attention. Now, this is for private insurance. I realize that we're sort of in an era now where you can do Medicare shoulders, and that's all fine. It's actually really good for volume in the outpatient setting. But I'm talking about if you are bundling if you're trying to create a bundle with a private insurer. You have to have a hip and knee replacement, I think, in order to really get their attention. We used EOB forms to gather baseline costs, and we approached insurers individually. We started with Cigna, and then once that deal got hammered out, all the other 6 major insurers got in line in our market. So I said it's a bundle, but it's not really a bundle. It's called a carve out, but it really acts like a bundle. It's a 90-day episode of care that includes the facility fee and the implant. We did have to go through a process to get better implant prices, who were actually much more responsive than the insurers, actually, when we were going through this. we are offering the private insurance companies a way to save money, and we were going to be costing money to the implant companies, and still the implant companies were much more on board with working with us. It was kind of an interesting experience. Anyway, we studied our carve out cohort versus our non carved out or unbundled, and as you might expect, the more competitive implant pricing really drove significant cost savings. So the net result here is that this is the rare win-win in medicine. You have insurers that are pleased because they're saving money. You have patients love it, especially if I would start calling them like Andy does. But overall costs to the healthcare system are reduced because now insurers have begun to track these episodes of care. And we're actually working on a few prospective bundles to see if we can essentially warranty this stuff up front. I'm not sure that's going to work out, but it's certainly been successful enough for us to have that conversation. And of course, as surgeons, we do better because we're doing more cases more efficiently. And if you're in an ownership environment, you do benefit from that. So reduced costs, better satisfaction, that does mean value in this era of so-called value-based care. I think that's all I got. Thanks.
Quinn, that was outstanding. I got a question for you. You just came back from an interesting conference as well. What do you think can be done to prevent a race to the bottom in pricing for bundled payment? So as the insurers know that it's profitable for the institutions to do this, what do you think is going to be instrumental in preventing erosion of the bundled payment?
I don't think that it won't be. It's going to be eroded, and we're really playing a staving off type game, and this is what we're doing in medicine anyway, right? Costs are going up, reimbursements going down forever, and at some point we are going to reach an inflection point where that's not sustainable anymore. The tack we have taken is to we actually have a fairly fragmented insurance market here, so there's no one dominant private insurance company. So by being able to play with all of them, we have been able to secure some leverage for contracts and for these bundles. And so they have not, to my knowledge, we have not had to go down on a bundle with our private insurers. And then the Medicare is just going to keep chopping until people aren't going to do surgery anymore. I mean, I hate to be that pessimistic, but I'm pretty discouraged at the state of the payment system.
Appreciate that insight, Quinn. Thank you very much. I think what we'll do is move on to our next talk. We'll have more time for discussion at the end. I asked Dr. Murthy to talk about how you can build a very high volume practice in a very competitive market. The Baltimore, DC area, unbelievably competitive, and Anand's built a huge practice there, and it'd be great to get some of his insights on how he accomplished that.
Thanks, John and Hafiz. Yeah, I'm retiring tomorrow. No, just kidding. All right. So, this is putting together this talk was interesting. I've been here a long time now in Baltimore. It's my only city I've worked in. I've had 2 jobs. I went from a completely university job, and I'll talk about where I've been for the last while or so and how it started out, how to grow, and how to maintain. So in the beginning, I was a fellow out of Columbia. I really wanted to get an academic job. I had to come back to this area. And Dr. Biliani, Dr. Levine found me this junior sports job at University of Maryland. And then the new chairman transitioned me to a shoulder practice over 3 years. In my first year, to those who are early into practice, I think I did around 9 arthroplasty and 120 cases. And this was before the advent of reverse and how Jawa has gotten so busy over the last few years. Don't have FOMO. I learned this from Hafiz over the weekend where we gave some of these similar talks. Patience, patience, patience. It all starts with being a good doctor and a good surgeon. You're not going to be in most cases, and every situation is different, like Andy said, but you want to be a good surgeon first. And I don't even know what a high volume surgeon is. I do about over 200 arthroplasty, but 600 cases. You want to define your practice, whether you want to do a lot of arthroplasty, arthroscopy, trauma. I have a significant elbow throwing injury practice. And you have to practice. When you're early, you want to be a good low volume surgeon. So you got to practice, get better at your trade, get better at being a doctor in the clinic. Be humble, be reputable in your community, help your colleagues. You're going to be in most places the smartest, best shoulder surgeon in your region, and be willing to help your colleagues, your colleagues who aren't as knowledgeable about shoulder problems, revisions. Offer to take on that revision and be that go-to guy early in practice. So starting out, keep calm. Don't worry about, coming in and being the best shoulder surgeon in the region and I should be doing 100 replacements in a year. It's going to take time, especially, a lot of people like to go back to big metropolitan areas, New York and Boston and DC, Baltimore, and it takes time when you have a lot of other surgeons around. So when I first started, there were 2 fellowship shoulder trained surgeons in this area, and now there are 12. And as people come in and their health systems that really want to compete and get market share, you have to continue to maintain and innovate. So what they say always, you have to be in the room when decisions are made, right? So at the hospital level, your department level, at the system level, you want to meet those decision makers early on and then maintain that relationship, whether it's with your chair or your hospital CEO. At the system level, go to those meetings and be a face, show your face, so they know that who you are and what you bring in. How to grow? I think this worked for me a little bit, both at the local, the regional, go to meetings, national meetings, and then international meetings if that's what you want to try to build. I did that early on, and it was, while daunting, it really helps you to network. I just got back from India, and we're growing kind of the Indian American. John, you don't remember this picture. This is from 2024, I think, in Brazil, which was great. It was my first
Yeah.
international meeting. And you meet people and you network and you make friends and colleagues for life doing that. So I think going to meetings, building your brand, you have to be comfortable. Some people are introverts, some are extroverts. Don't be ignorant to social media. So try to set your goals. What are you trying to do? And define your personal brand. And I know the guys on this call, respected, good surgeons, good doctors, trustworthy. So you want to define your brand, whether you're going to be really professional, reputable, or notorious, and you want to help build that brand. So one of the early things you can do when you have time, so when you're early in your practice, you have time, is starting local shoulder meetings where doctors usually aren't going to come, other orthopods, where you get therapists, ATCs, primary care, nurses, PAs. I use LinkedIn to build my professional networking and colleagues, and that's exploded the ability to contact even people out of orthopedics and business and in teaching and education. This is my kind of list of social media that I use, and I really focus kind of on LinkedIn and Instagram. I have chosen education and mentorship to kind of be what I like to do now at this part of my career. This helps me to kind of gain that following, get my message out. Podcasts are good. Scott Sigmund, the Fro, he's been great. Danny Acevedo and Sharif and Logan and Ashley on the Sports Docs. And this enables you to kind of get your message out as well. I think promoting research, if that's one of your things you like to do and are good at, is in your skill set, is something else you can promote on Instagram and LinkedIn. It shows you have that educational background, that specialist, that leadership in this area that most sophisticated patients like to see, especially in those metropolitan areas where it's really become saturated. If you also want to work on the industry side, they can give you clinical support to do research, run labs, especially on the local side, medical education, journal clubs. Meet with your local people first and then branch out. Reviews do work. They do affect your practice, good and bad. The only way I know is for bad reviews to push them down. My athletes, I asked them all to give us reviews. I found some reviews online. This is Andy Jawas. Couldn't find anything bad. However, I think he needs to work on the office cleanliness. This is Quinn's, did not do a block for shoulder surgeries as most people do. He's 11 out of 10 pain. He's quite cold, rushes through the visit. Gupta spent 10 minutes chatting with another person about trivial matters outside of my door. Don't make it obvious how we're waiting for nothing important. These are all funny as I found them. This is the only one I could find for mine. Dr. Murthy does amazing work. My son had 75% tear, blah, blah, blah. So, just kidding. But everyone has bad reviews. I had some where I was on call over the weekend. Somebody didn't get narcotics, and that bad review is at the top. And so you got to push them down. Unfortunately, there's no way for us to control them other than do that. So I'm going to finish with communicating with referring providers. And so that is important. I think it's important, just like Andy's communicating with his patients, trainers, ATC. There are arthritis centers in almost most metropolitan areas. My biggest hit rate is being able to connect with our big local providers on the physical therapy side. And I give them my cell. They contact me with acute injuries all the time. They tag me on their social media. We have in these areas like Baltimore, DC, and Boston, huge young sports, club sports and athletics, and you can get a ton of athletes. They don't need arthroplasty, Andy, yet, but maybe if they get too unstable, they'll get a reverse. I give my colleagues my cell phone. They can text, email me, use Doximity Dialer. For patients, they can't call you back. You can call them. Some docs will give patients their cell phone. Some advice I've gotten over time, send images of the finished product to your referring doc with a text that they did great. Don't say yes to everything, but most things. Build your brand. Don't sit in judgment, however difficult, of referring docs. Your job is to take care of that revision patient. Say hi to docs in their private practice. Leave cards. Meeting, we have just hooked up with some local urgent cares for trauma. I have a junior partner, so now we can get a lot of cold trauma. Like Andy said, the staff is going to be a huge source of referrals. When you start out, be kind and humble to that nurse and OR staff and anesthesia. Be the person early on with open lines of communication. Same thing, word of mouth is the best. I have never had a marketing program in 20 plus years. Word of mouth is the best source of marketing. So same as always, these are the 3 A's of success. Be available, be affable and kind to everyone you meet, and practice, practice, practice to become able. So in summary, know who you are, what your skill set is, get help, go slow at the beginning, and reach out to your mentors. I do all the time still, and good luck.
Anand, that was absolutely superb. A lot of work went into that talk. Thank you so much for doing that. I'd like to get your perspective on touch points with patients. So over the years, Anand, how often do you see your patients back post-operatively? And what have you found is the sweet spot for that, where patients want to see you, but perhaps it makes your clinic overly busy? Love to hear your perspective.
So I see all my new patients, whether the fellow sees them first and then I see them. And then typically my PA will see them at the first post-op visit, and then we'll kind of tag team like Andy does, kind of back and forth at that, it's typically 6 week, 3 months, but we're always together in clinic. So if there's ever an issue, even at that first post-op, you just, like Dr. Biliani taught me, the more you touch them, put a hand on their shoulder, let them know you're always there, that is plenty. You don't need to be in the room for a long period of time, but you need to make that physical contact, I think.
Great advice.
I just want to add one thing that Anand said. I learned that from one of my mentors as well, Jerry Williams, way back when. You have to, the moment you can, touch them, right? And it's a little bit of, it forms a connection. So when you're doing your physical examination and you're doing whatever else, and you want to sit next to them, and never sit or stand above them. If you at all possible, sit below them, right? And so that you're looking up to them. It makes a huge difference.
Always ask what questions they have at the end. These are kind of typical things you learn, but when you have high volume, whatever that is, you tend to get rushed. And I tell our fellows, never put your hand on the doorknob on your way, trying to get out. Always sit. It makes you stay in the room a little bit longer, and then, if you touch them and examine them. So many patients come to me, I'm sure you guys do, say, this doctor never examined me. They never even examined. They looked at the MRI. They never even touched, examined me. So some of the things are simple, but, just got to kind of make it, over and over repetitious.
I think the key insight there is that doing those things gives the perception that you're spending more time with them. Like a lot of us are still of that era where in medical school, we were told, if you just let the patient talk long enough, they'll give you the answer. We can't do that.
Right.
Even in Andy's clinic, that you just don't have enough hours in the day for that. So you do have to guide the discussion. You have to control it in some way, but doing those things and I think there's some surveys and such on this where if you do the things that were just talked about, then the patient thinks that you spent more time with them than you actually did.
Awesome. That was so well done. And I think now we're going to hear from Dr. Gupta, who's going to talk to us about cutting through the red tape, how to make an academic practice efficient.
So even during this, pardon me for a second while I load this up, even during this talk, I have been editing the talk because I don't want to be redundant from what everyone else has talked about. These are my disclosures, and my task is to focus primarily on the academics portion. And so one of the things you've heard from many of our colleagues earlier in this talk is how much you have control. In an academic practice, you have to, and when I'm talking about academic, I'm talking about a true being employed by a university. And the goals of the surgeon are very different often than the goals of the organization. We as surgeons want to showcase an individual, whereas administration often wants to showcase the entire organization. And when you're talking about control, you have to understand that what we control in an academic practice is much less than someone who in a private practice or private-demic practice. And that's very true both in the clinic and the OR. But that doesn't mean that you can't succeed and excel. I've just switched to a new role, new opportunity, but 3.5 months ago, my volume was I'll get to that in a second. You have to lead by example. And the reason why is you have to figure out what are you going to be good at? What are you going to be better than your competitors are? And mainly you want to inspire others. And it's likely going to be your clinical work, your work ethic, your research. It's almost never going to be your administrative skills. And using along the lines in an academic practice, when 3.5 months ago, when I was in California, I was doing my average between 425 to 475 cases a year and about 125 to 150 arthroplasties. Now, about 3 or 4 months into a new practice, I'm starting all over again. And this was a month into my practice, this was my first shoulder referral from the group, right? And so that's what we do what everyone else on the call has to do. You do the big whack, and a month later, now I started getting some of the easier cases or more routine cases. The guiding principles, what I want to share with you are this, okay? Is that you use the strengths of your the academic institution to your advantage. And I'm going to go over that in different components. First, personnel. We have in most academic practice, you have medical students, you have residents, you have fellows, you have partners, whether they're junior or seniors, as well as physician assistants, nurse practitioners. And you have to factor in how each one of these individuals actually has a direct role in what you can do or shouldn't do. And we're going to talk about that momentarily. You want to understand that within that academic institution, how are you going to increase your visibility and networking strategy? One of the things that Anand just spent a time talking about with physical therapists and whatnot, you have that. But most academic practices, you have a built-in primary network within your system. And so you want to go and spend time with those primary care doctors. You want to spend time in the nursing school. You want to spend time in the physical therapy department, because all those people, as they spend time with you when you're first in practice, I am doing all those things right now. Even though I've been out for 20 years, I'm redoing all those things because I'm at a brand new university, and I'm spending time at the primary care lecture giving a talk about shoulder pain, so people know who I am. Because it's not like as if there's a shortage of shoulder surgeons in the Omaha marketplace, but I have to redo that. You got to establish your niche. By doing that complex revision case, people say, okay, he's not going to be afraid of anything. He's not. And so the reality is I'm a little older than some of the folks. And so you want to do that. Are you going to showcase new technology and techniques? Those things also help your niche. We are starting to bring in AR into the operating room. No one else has done that, so it brings a little bit of buzz. Nothing beats your patient outcome, just like Andy talked about. So right now, they haven't done it before. I am starting to establish how are we going to measure the patient outcomes of the people that we're going to be using. And all these things show my primary care colleagues, the nurses, the physical therapists, hey, this is what I am doing as a new shoulder surgeon in your established market. You have to understand the strengths of your academic institution. And this applies to research. Now, when you're doing research, you have to figure out whether, as a shoulder surgeon, the research that Dr. Jawar can do is going to be different than other folks. When I was at University of California highlighted basic science and molecular biology. There are pathways, there are collaborators. That's what my R21 is about. It's about the molecular biology of looking at satellite cell senescence, right? And so the reality in rotator cuff, there's no way in my current institution I can do that. So I'm looking at doing education, looking at imaging research. You have to highlight and figure out at your own institution, what are the research opportunities? Who can you collaborate with? Because most of us are focused primarily on generating as much work as we possibly can clinically. So in order to do the research, you can't reinvent the wheel for everything. Now, specifically, some specific things that I thought to talk about in the clinic status. You got to use your team appropriately. So when you're seeing in the clinic, I quickly, the night before, I look at which are new patients and there's always a little blurb, which are new patients, which are complex patients. So I assign the complex patients to my residents and fellows to see. The routine patients will be assigned to the mid-level or the PA. And I do that from the get-go. As soon as I have then a sense of where they're going to be, I'm going to triage the patients that are non-surgical cases to my mid-levels, and as well as a pre-op counseling. I've already established dedicated slots for follow-up visits, post-op visits, injection visits, and even virtual visits. I'm fortunate some folks from California want to at least talk to me. I don't know that many are going to come to Omaha, but their idea is that because if they're going to get on a plane, they might as well go see Dr. Sperling at the Mayo. And the reality is, I'm establishing my referral base and getting busy as I can. One of the things that's helped is developing standardized clinical pathways. When we all have these pathways, this helps the nurse who's assigned to my clinic, because that nurse changes. I don't always have a dedicated same nurse, but I hand her these are the pathways, and this is what I'm going to do. Now, at the beginning or at the end of your clinic time, I structure review rounds where the challenging cases, patients, I tell the medical student or the resident that's with me for the day, please take down notes, and then we will go over those at the end of the day. So as to not disrupt clinic flow. And that actually also applies to OR efficiency. One of the most important thing is when you have mid-levels, you have residents and fellows, you want to define the roles of each of these individuals before the case start, right? You want to, who's doing the exposure, who's doing the closing, who's putting the dressing. And it's very, very so that everyone's role is defined. We have a huddle before the case, when we redefine the roles, and at the end of the case, a little bit of debrief. We talk about that on it, but I actually use that with each of my cases, and it's at that debrief where we actually some of the most or the best efficiency is. And then I haven't been able to do that quite yet because I've just been here for a few months, but I had done in my previous role, and I strongly encourage folks to look at the idea of having high efficiency OR days where there's going to be fast turn and surgeon-like cases, whereas longer days, like whether you're for academic case, meaning the revision case and whatnot. And I have found that very important when I'm trying to, so that I don't do so much the, simple arthroplasty in the morning versus a revision case in the afternoon. But what I tend to do more is that this is a routine day and this is a complex day. And so that I'm mentally prepared for how I'm going and who is allowed to do what in the cases. You got to expect the unexpected, right? in an academic practice, you're not going to have a consistent dedicated OR team. You're going to be missing instruments. There are things that are going to happen. And so you have to have in your mind, be prepared for that, because the biggest challenge that I have found, and now being in 2 different universities, it doesn't change. The amount of control that you have is limited versus a true physician-owned practice. You got to make use of your downtime. When I know there's going to, some days are going to be delayed for a start. I know there's going to be time in between cases. So that's when I always have my laptop. I'm prepared to write a paper, edit a manuscript, review an article, as I know there will be downtime, which I cannot control. So I maximize my efficiency by making sure that when there is downtime, I'm going to use that for something else that's more efficient. And so at the end, sway your shoulders, stand up for your principles, and just do the best you can for your patients. Thank you very much.
Terrific talk, Ranjan. Thanks for putting that together. I thought one thing that'd be interesting just to go down the panel and hear about. One of the folks on the call, WebEx, texted me this question. Everyone on this panel has been incredibly productive from an academic perspective. Love to hear, Andy, starting with you and then going down the line, how in your practice you were able to go ahead, even in a private emics type setting or whichever setting you're in, to be able to carve out the time to be able to build that research machine. Andy, we'll start with you and then maybe go down the line.
Yeah, so I think it took a long time. I wasn't very academic in the beginning. Ironically, I was in an academic institution because I wasn't really able to create a registry. And it actually started in about 2015, about 8 or 9 years into practice, where I'm like, look, I want to keep track of my patients. And so I start with an Excel spreadsheet. Then we all of a sudden have all these things like REDCap and other things, Obaird. And then it took a couple of years until you got enough registry patients to actually do something. And then once you get a fair amount of patients in that registry, you could just, cut the data so many different ways and really spit out a lot of ways of looking at things. And that came with super specialization. And I do it in between patients, like Rajan said, in between cases, things like that. So it took a while to build up that practice.
Ranjan, I loved your talk. I loved your perspective on using the resources of the institution to try to understand what are the different strengths. I liked how you compared what you had in California to what you have now at Creighton and being adaptable to that. Maybe just a word, Ranjan, about funding, the funding for the research, how you've been able to go ahead and craft that, which for many folks is a challenge. I loved how Andy got his group to be able to get funding in terms of a foundation to support it. Ranjan, how about for you, in your perspective, in getting funding for research? How have you done that at both places?
That's a great question. A lot of it depends upon, you have to have a vision on arrival to your new institution, right? And it's the expectations that you have with your boss and whatnot. So in my last job, I was hired as a tenure track orthopedic surgeon with the expectation that I would have NIH funding. And so my success was judged based upon whether or not I got KO8, R1 and whatnot. And it was without a doubt, like there was the initial funding came from the University of California for a very brief period of time. And so that was negotiated on the start. And now in my new role, so I've hired 3 people in the 4 months, and one of those 3 individuals wants to have a dedicated research component, and she's going to do orthopedic biomechanics. So that was part of our negotiation that I carved out with the dean and the CEO of the hospital, and provided that from the get-go. And so it's about expectations. Now the joint surgeon who is not as that I hired is unlikely to be getting NIH funding or extramural funding, but he wants to establish joint registry. So I was able to leverage money from QI projects from the hospital to say, okay, we're going to establish a registry and do this sort of things. And so a lot of it comes from, there are buckets of money, and it's a function of trying to get people to align with the vision of why they should help you from the get-go. The other part is there is a timeline. Okay, like in my first job, my boss told me if I am not funded by 3 years, right, within 3 years, you go back to being a full-time clinician. There's the same thing. And actually, I've done the same thing. You set expectations.
Yeah.
If you're going to have protected time or dedicated time, it's for a finite amount of time. There's no bridge funding. There's no whatever else. It is, you're going to get this within the finite time. If you don't succeed, then you move on, and we're fortunate we get to be great clinicians.
Yeah, terrific perspective on that. Thank you. Anand, you know, one of the things that strikes me every time I see the research you do, you always go after very clear clinical problems and then really try to ask the question to be able to solve that. So not esoteric questions, but very practical questions. Maybe share with us a little bit about how you've been able to get that research machine up and running, Anand, to be able to continue to produce research in your setting.
Yeah, I think you have to try not be too kind of shotgun at it. Try to focus maybe what's your question you want to answer. I mean, if you start out in practice, if you get one paper a year done, that's great. And then you're kind of branch out. And that's what I did early on. Since I've been at MedStar, we have an awesome biomechanics lab. So that's been great for the fellows. It's hard to get a project done in a year. And so they typically all do a biomechanics project along with their clinical projects. And then over the last couple of years, since we're affiliated with Georgetown, we have this great group of like 8 to 10 medical students who are all wanting to do research now. It's really hard to get into orthopedics. So we meet regularly. We have review papers and data analysis and structured projects, summer projects. And so those medical students are incredibly productive and can help build your research program. So, but in the beginning, I'd say to stay kind of focused and try to get a few good questions answered.
Yeah.
And then kind of branch out when you build your research team, if that's what you want to do. And you can always do research in private practice too. It's a complete fallacy to think you have to be in a big university place. You can do it, especially if you use a registry.
No, I appreciate that. Great perspective. Quinn, question for you. You know, I think you've really done so much in terms of our perspective on outpatient shoulder arthroplasty, and thinking about the financial aspects of this in terms of how you view this, Quinn, working with your administrative partner on the contracts, on the billing, on the financial aspects, and balancing that out, understanding when do you need to be there with them to address these? When do you hand it off to them to be able to go ahead and address contracting issues? How do you balance that, Quinn? What's the right amount of engagement? And what have you learned that you can share with us?
Yeah, I got to think highly variable by the situation. Of course, in Gupta's situation, I think the contract's probably done for him, I would imagine. And so we contract individually, like I said, and honestly, the picture that I showed in my talk was our CFO at the time is now our CEO, and he was the financial architect of the outpatient joint program. It was his idea to create bundles. It was his idea to try to scale this beyond just doing one-off. So I really credit his vision. We have a fairly robust physician leadership structure within our group, but there wasn't really much physician involvement in negotiating contracts or anything like that.
Perfect. Hafiz, any comments or questions for the group before we wrap up here in the next few minutes?
No, I thought that was fantastic. Thank you all for being here. You know, the only other question I had, which I know is on the mind of a lot of people mid-career and early career, is Dr. Murthy, on one of your talks, you mentioned that when you started, you had 2 shoulder and elbow surgeons in your area. Now you have 12. So the question, I get asked all the time is, how do you deal with competition? Because I think we're kind of in this situation, especially in all this talk about academics, you're very often training your own competition, right? Because they're in a place that they want to stay and they want to be. So I guess
sure people like you never come around.
So I guess I'm not moving to DC. So I'm right.
I'm coming to OC. That's right.
That's true. Right. Exactly. That's my real question. So I guess just quickly, like how would you kind of advise what mid-career young surgeons? How do you deal with competition? How do you deal with training your competition, and how do you deal with people moving in?
Yeah, you worry about people coming in, right? You worry about your market, right? I tell you, it's a lot of things that are out of your control, but I would tell you the things that work are to be inclusive to those people who come to your area. Especially if you're doing really good work, be inclusive to them, and you'll be known as that person who was the inclusive one, and still you're above the fray. Okay. and invite them to those meetings, those journal clubs and things like that. And they'll understand what their skill set is, what your skill set is. Once you've established it, it's really hard not to maintain. That first 10, 12 years, I think, is really important. And so I think that's how you'll maintain with the competition. I haven't got, if you begin to be that doctor who's like, a bad mouthing person or a doctor against new competition that's coming in, it'll probably backfire on you, in the long run. So I would tell you to be inclusive. When you build good shoulder work, this is what people have not understood, even at the health system level. They think if you'll split the pie. If you actually bring in good people, you'll build the pie. So Evan Flato always taught me, hire good people when they're available. They can grow it, Don't always wait till you think it's a time or a need. Hire the good people. It's always worked. Every time I've hired someone new, you take like a little dip maybe in your volume, but then it goes back up even more but you got to hire the right people. I think that's probably important too.
Well, I want to thank our faculty so much. What a great time this evening. Really appreciate your insights. The talks were superb. And this talk will also be available, of course, on the ASCS website. But again, thanks so much for joining us tonight. And Afis will be helping to run our next practice management WebEx coming up in just a few months. But again, thanks so much for everyone for being here.
Thanks, guys. Enjoyed it.
Thanks,
Have
guys.
a great night, guys.
Good
Thank you
night.
so much.
Thank you so much. That was great.
Take care. Bye-bye.